Hello, good evening.
Good evening, sir.
I hope everybody is fine.
Yes, you.
Good, I'm also fine. If somebody send me the food to the link, I want to join another device. So if somebody has kindly send it here.
Come again.
I want to get the fast food link. I want to switch to another device, but if anybody has the fast food to the link, kindly make it available to me.
Okay, your voice is low.
Okay, I'm saying that if anybody has fast food to the link, I want to join with another device. I will exit this one, but I want the course code. So I mean the link code, the pin
Someone
code
sent
or
it to
code
the
which is
chat box.
or put it in the chat pic so that I'll pick it from here.
Yes.
Okay, I've seen it. Okay, thanks.
Yeah.
So where are we now? Where have we got to? Where have we gotten to now? Where are we now? Hello.
So please, we are on classification of computers. That's under computer hardware.
Computer classification. Then you guys are far behind. Wow. Ish. We're still on computers. Okay, so can somebody brief us? Just give us a brief take on that. Then we move on from there. My journey, yeah, network now. Hello.
Hello.
Yeah, I'm waiting to hear from someone. So who is uh, um, beginning the journey with us? You guys are far behind. So don't let me be talking before you come in. Who is starting the journey with us? Okay, now let me go to Janet. Actually, Janet,
Yes.
yeah, can we hear something from you?
Okay, please. I want to take us through the computer part. The computer port. Sorry.
Okay.
It said the port serves as an interface between the computer and other computer peripheral devices. And then under that, we have the serial ports, we have the personal system, then the VGA, the internet port. And then also you said that computer under the under nursing perspective is that it is synonymous to nursing informatics, but not nursing informatics is not the same as computer.
Carry on. Move forward.
Okay. So we also got to know that some part of the hardware, we have computer hardware and then we have the software. So the hardwares are the ones that we can touch. And so with that, we have the processor and the memory. Then under that one, we have output and then input devices. The inputs are the ones that like the information we put on the computer, and then the output is the data that we gain afterwards. So please, that's all.
That's all you can say.
Yes, please.
Okay, a beggar has no choice, so thanks for the feedback.
Okay.
Because of our time, you are far behind. So I think we are done with the network and internet, or we are still there.
No, so we
got to, you said
supercomputing. Concept theoretical.
So did you go through classification of computers?
Yes.
And then we also look at operating system, right?
So I think the last time we ended on theoretical model.
Yeah.
So how come that somebody was taking us back to computer systems? And that is the reason why I made admission that you are far behind. Did you were you introduced to this topic, or?
Yes.
So where exactly were you exposed to this model? Did I show you this?
We ended on the here.
So I walk you through novice through to the expert level.
Yes, please.
That means that we are done with the theoretical models, right?
Yes, sir. We are done. We are done with that.
So how come that some of you are taking me back to computer classification of computers? You don't come for lectures. You come and then you exit without anybody's permission. Then you come back and then you worry us. Okay. Anyway, so let's begin looking at. Did you look at relationship between data, information, and knowledge? Did you look at this?
Yeah, we are yet to go here. We've not started anything on this one yet.
Okay. So in our last meeting, we look at levels of skills acquisition, or those theoretical models. We said that the model is what we see as that structure, but embedded in the model is the construct. So you see the novice, advanced beginner, competent, then you go through proficient to the expert level. All of them are noted as a key construct that defines the complete model. And then we look at who a novice is. We give several instances. And then we also look at advanced beginner. We make comparative, analysis between a novice and advanced beginner. We look at special traits in all these set of skills. And then we look at competence, and that also proficiency, and then experts. So I ask you to do a candidate assessment of yourself and confirm where you can associate yourself, right? So this evening we are looking at relationship between data, information, and knowledge. You have already been made known that these serve as the major pillars of nursing communication. And therefore, we are going to look at clear linkage or relationship, either among or between them. So data, information, and knowledge are key components of nursing informatics, and they help in understanding clinical information systems and their impact on healthcare. By the end of this session, students should be able to tell us what you mean by data, information, and knowledge, and its relationship in nursing care or in relation to nursing care. Then you look at a clear relationship or linkage between or among them. So let's begin the journey this way. Back then in school, we were told data represent what? Raw facts. But at this level, you get to know that data are described or is described as what? Discrete entities that are interpreted, objectively, or that do not require any interpretation, right? Let me put it again. they are described as discrete entities that do not require any interpretation. So on the basis of this, if I say my name is what pipe, I mean my name is let's say Kennedy, the way you see, you don't require any interpretation, right? But let us picture it this way. In your examination, once we raise, let's say, data as an element or just data set, like demographic information or any data elements, you are supposed to make sure that you confirm whether it depicts data, whether it is information or knowledge. So we are going to begin our journey this way. You know, they are very important because one leads to the other. So I want somebody to take vital signs and then try to give us what the relationship or linkage between data elements being a vital sign. Then you tell us how vital signs can tend to become information. Then how it can also be formalized to become what? Knowledge. Please, is it clear to you? Please, is it clear to you?
Sir, come again.
Okay.
Sir, please come again.
Okay. I'm saying that now we are going to look at what defines data. And data, just as I've made it known to you, they are described objectively without what interpretation, okay? Or they are seen as what discrete entities that are described objectively without what interpretation. So on the basis of this, you are going to identify data set or data elements. So we are going to make it more, it's going to underpin the things that we do. So I've cited an example like vital sign, which is considered as what data elements. You want to look at what relationship between vital signs, right? Then how the vital signs get, transformed into usable information, and how we can also formalize, vital signs through the application of what our knowledge. And that is how I want you to just, give your description or base your description on. Is that quite clear? Maybe I have not been able to give you an example. That is why, okay, let's begin this way. In 1986, Bloom introduced the concept of data, information, and knowledge as the framework for understanding clinical information systems and their impact on healthcare. He did this by classifying the then current information systems by the three types of objects that these systems process: data, information, and knowledge. And I'm saying that if you pick, let's say, vital signs for an individual heart rate, respiration, temperature, among others, how do we give meaning to a vital sign to make it information? Because the moment you ascribe some relevance or significance to vital signs, it now becomes what information. So I want you to sequentially look at vital signs and how you can establish clear linkage among these variables. That is data, information, and the knowledge. How do we have information and knowledge from what? Vital signs. Please, are you getting it?
Sir. Yes,
Yeah,
sir.
hello. Okay. So let's see how goes. So let's see how it goes. Yeah, those of you who are complaining that you are not seeing the screen I've shared, maybe it is coming from your end. So reposition yourself and then get a clear picture. Okay. So who is beginning the journey with us? We are far behind time, so don't let me be talking before we come in. Even the Sunday lectures, but sometimes looking at the time now, we are managing. Prince, okay, my friend, can we hear you?
Hello, sir.
Yeah, Prince. Yeah,
Please, to my understanding, let's say we want to measure the BP for all clients on the ward after maybe a simple ward activity, and then we choose. So when we measure their BP, it is going to give us a raw data. But
Okay.
if we are able to know that maybe after the exercise, almost everybody's BP is at least it has gone up, then we can now interpret and say that after every exercise, all the patient BP have elevated, and then that one will be our conclusion or the knowledge that we can get.
Okay, you said that one would, confirm formalization of what the knowledge, or maybe you draw conclusion based on those abnormalities, right?
Yes,
How
please.
do you also give some meaning to those abnormal ranges that you are seeing? Because you have not given a description of what constitutes information. But once you draw conclusion, the conclusion confirms
Okay.
formalization of what your knowledge. Are you getting it?
Yes, please.
Okay, so can you go back, and then I want you to follow chronologically. That is just from data, information, and then knowledge. So you tell us that this is what a data element, that is the vital sign, right? And then this is the information, and this is what knowledge. Okay, so let's go again, if you wouldn't mind.
Okay, so after measuring the BP, we can see a clear cut that all the BPs are elevated, and we can interpret from there, which is the information side, that the active, because they all did the same activity, that is why the BP has gone up or elevated small. And then we can now deduce a knowledge from it that after every activity, all patients' BP has elevated. Maybe you're not getting, that's my explanation.
So based on this one, does it become, information or knowledge based on, your idea of maybe the happenings? Does it confirm information or maybe knowledge? Because once you draw conclusion, then it means that is what knowledge. Are you getting it?
Yes, please.
Okay. So the example that you choose, that's a very good one. You have been you made it very clear to us that you check the BP, and you are getting, let's say, different set altogether that do not maybe necessarily fall within the normal range. So once you are able to see that, then there is a clear indication of what something happening, because you are getting abnormal values, right? That is confirmation of what information, because you are able to attach some relevance or significance. Please, are you getting it?
Yes, please.
Yeah, that is a typical case of what information. Now let's see the formalization that will make it also look like what knowledge. The point I'm trying to establish here is that you have used maybe the vital signs, right? And for instance, I'm saying that a serious set of vital signs taken over time, right? So those ones that you took severally, were able to place those values into context, right? And based on that, you attach some relevance, or it gave you, an idea of the likely or the probability of what will happen. So on the basis of that, it turns out to become more information. But if I may also want to, or you want to complete the knowledge.
So please, this is how I understand it. So if my colleagues will also come in.
Okay, so somebody should also give us, a different, perspective. You can also share whatever you think about this. Okay, now let me go to. Are you following the conversation? Because I'm doing this because in the examination, nobody is going to ask you to define data, information, and knowledge. You are going to situate the context in line with what the things that you do. So they are going to be application-based questions. So if you set, questions and options. Maybe you are supposed to exemplify those options to a statement. You are supposed to tell us whether it is what data, information, or knowledge, and that is the reason why we are going through this, right? Okay. Can we have another person before I make progress from here? Now, Same, can we hear from you?
Okay, sir. Good afternoon.
Yeah, good afternoon.
Okay, sir. So let's say when the patient comes out of theater, and then the patient is in a recovery ward, and then you are checking the vital signs. So you check vital signs for maybe an hour or two, and then you've seen that the patient pulse is high, but the BP is going low. So the raw data is the pulse and then the BP.
Okay.
So you have to draw information to know that, like the ones, if the pulse is high and the BP is low, meaning that the patient is the patient is going hypotension. So you can know that if the patient is going hypotension, since the patient now from theater, maybe the patient is having an internal bleeding or there is a bleeding inside. So based on that, you can make the conclusion that the patient is bleeding, so the patient has to go back into theater. So I think that's a little bit that I know. So I don't know whether I'm right or wrong.
Okay, so that is your view about information, right? It turns out to become information.
Yes,
so how do you
and then you get
distinguish between information and knowledge?
So the knowledge is your conclusion that if the PP is going low and the pulse is going high, basically you have the knowledge that this is hypertension. And since the patient is straight from theater, maybe the patient is having an internal bleed. So based on the knowledge that you have to send the patient back into theater and open up and see where the bleed is coming from.
Okay.
I don't know whether I'm right or wrong.
Okay, so I'm getting your point very well, but once you place it in the context, right, and it give you an idea of maybe what is happening, you get it? That is confirmation of what? Information, because now it is more organized, and you are able to place into context or assign some relevance, and then based on what you perceive to be the outcome, you propose an intervention that will, help the patient, and those interventions that represent what? Knowledge. Are you getting it?
Knowledge. Yes, sir.
Yes. Yeah. So
the knowledge will be sending her back into theater.
Okay. Okay. So if that's it, one of the interventions is to, send the patient back to theater, that is also maybe application of what? Knowledge, right? Okay, good.
Okay.
Can we also get another instance? Okay, so let me go to, so thank you. Now let me go to, is it Simon, right? Or Simon?
I was also looking at it as in this way. Let's say temperature pace. The patient temperature, patient the data.
Please, who has also been made co-host? Okay. Abby, I think Abby and then Ben, you are co-host. So if somebody come here to disturb us, put them at the waiting room. Okay, my friend, carry on.
Yeah, so once you are going to check the patient vitals and then the temperature indicates 38, that one is the data. Then after the data have been taken, then you are able to interpret that, yes, the patient, the temperature is high, then there is an infection. Then we can say that one is an information. Now, when you intervene, then the patient, the outcome on the patient now become the knowledge.
Okay, so what you put in place to remedy the situation, that becomes a formalization of knowledge. So let's bear this in mind. The information I'm talking about is a group of data elements that have been organized, right, and processed so that one can interpret the significance of data elements. So that is why you check maybe more range. Then you want to get a confirmation one. So you do another one. So if you do it and then you're not too sure, knowing very well that it falls within here because you are able to situate the data set into context of relevance or significance, right? And then that becomes the information. I'm thinking that this intervention will resolve, the situation. And that is what? Formalization of what? Knowledge. So knowledge is built on formalization of the relationship between data and the information. And knowledge base. Okay, now I will not make progress to this one. I think the example is okay. So I want you to look for more examples of what data, the elements, then look at information, and then see the kind of intervention or try to formalize it to make it what? So that somebody also come in. Now, if I want to, let's say, determine somebody's body mass index, I will have, let's say, height, weight, and age. Or maybe I may consider gender, right, as data element. Please, are you getting it? Please, are you following the conversation?
So please come again. The line was breaking up.
Hello.
Hi.
Yeah, did you hear the question?
No, please.
No, sir.
Okay.
No, sir.
Now let me repeat the question. What I'm saying is that if you are having these as your data elements, example, height, weight, age, and gender. This one, I mean, how do you contextualize this in terms of what? The relationship into meaningful. Hello?
Hi, sir.
Did you get the question?
The line is bad.
The
Please, your
line
line
is
is breaking.
The network is bad. Really? Okay.
is breaking.
Maybe
The
I just
line
have
is
to.
not good.
My line is not good, right? I hope it's okay. It's okay now. I've repositioned myself.
Yes.
I think it's okay now.
Yes, it's okay.
Okay. So the question is, I've given you some data elements that are used to determine BMI, right? And I'm saying that you that want to contextualize that into formalization of what knowledge. I want you to draw that linkage or relationship using these data elements that are used to determine BMI. Look at what? Weight. Look at height, age, and gender. And you that want to draw, I mean, a clear relationship between data, information, and knowledge. Please, did you get it? Okay, so now let me pick from who is ready to talk.
Hello?
Hello. Is it okay? Is it okay now? Is it okay now? Hey, I'm going to say minimum day. Hello.
Hello, sir.
Hi. It's okay now.
It's okay
Sir,
now.
it's
So,
okay.
did you get a question?
Please come again with the question.
The question I'm saying that we want to determine BNI of, let's say, a patient, right? But we are using these data elements. We are looking at height. We are looking at weight. age, and gender. Contextualize this into formalization of what knowledge. What I mean is that use these data elements, right, to draw relationship or linkage among the pillars of nursing communication. That is what data, information, and knowledge. I hope it's quite clear now.
It's clear.
Okay. Hello. Hey, I'm chatting Nana.
Hi. Hello, sir. We can hear you.
Yeah, so go ahead and then make your submission. I'm also waiting to get the feedback.
Hello, sir.
Yeah, hello.
Yeah, please let me try.
Okay, try.
Okay, so whenever I want to measure the body mass index, we are going to use the height and the weight. So
Okay.
that is the data. That is the data. So let's say we measured the height. We had let's say 150 maybe meters, and then we measured the weight in kg. So that is the data. When we divide or when we calculate the body mass index, that is the information that we have gotten. And then we will use the information to make conclusion whether the person is, let's say, underweight, overweight, or having a normal weight. So that one will be the knowledge.
Okay. I think that is a very good one. So I want to find out from you. You confirmed, either the person could be underweight, overweight, or normal weight, or obese. Are they considered as what information or knowledge?
You drawing the conclusion to know whether the person is obese and all that, and that one is the knowledge.
That one is the knowledge. Okay,
Yes,
I think we use height, weight, and then age to make your determination. So once you have been able to contextualize that, and you are able to do the calculation of BMI to confirm whether the person is what underweight, overweight, normal, or obese. That is what I think information, right? Because you have been able to contextualize some meaning to those data set or elements. Are you getting it? But the application of knowledge will let you know that even though the person has BMI of so and so based on this, let's say the person has BMI of 30. That is your BMI over 40, but the person is still not considered as what obese. And that is a formalization of what? Knowledge. So we want you to look at it from the data element that you have. Then you do the calculation because you put them into context. That will give you some meaning or some sense. Then based on that, you confirm whether the person is what underweight, overweight, or normal weight. And that is what information. But your knowledge will tell you that even though the person is having BMI over 40, over 30, but it's still not considered as obese. I don't know whether you are getting the point I'm making.
Yes, sir.
Okay. So let's try to contextualize data, elements, and see how we can give meaning and then also formalize it. So the knowledge is the formalization of what? The relationship, right? And the things you put in place to remedy the situation. But in this case of BMI, what I want you to know is that you know weight, height, age, gender as well, data, elements. Then you contextualize them into meaningful information through the calculation of what? Your BMI. That will confirm underweight, overweight, among others. Then the knowledge you have will let you know that even though, per the clear signs that I'm seeing, the person may be over 30 BMI, but it doesn't make the person be obese, right? That is a formalization of what? Knowledge. Okay. So look for more examples. You can look at what hypertension. You can look at what somebody's sugar level. Contextualize it by giving meaning, and then you also formalize it through the application of what the knowledge that you have. So that is what I mean by data, information, and knowledge, or relationship between data, information, and the knowledge. Is there anything somebody want to know or ask? And you progress from here. Okay. In the absence of questions, then I suggest that you may progress from here. Everything that can be counted does not necessarily count. And everything that counts cannot necessarily be counted, Albert Einstein. So let's be guided or maybe ponder on this code as we move on. I'm not addicted to reading. I can quit as soon as I finish one more chapter. I'm not addicted to reading. I can quit as soon as I finish one more chapter. I don't know anybody who becomes addicted to reading. And that is the reason why when the semester comes to successful end, hardly do you see students, get themselves so busy. It doesn't happen this way, right? And that should tell you that nobody is addicted. You are there for a purpose or for a reason, and therefore make it count as such. So there's time for everything. Now look at this man. Let's take you from this man. He has dedicated all his time in reading the books around him. So I want us to look at what the man is doing and also take you from that. You have a lot of courses you are doing, and you are supposed to come up with very good grades. Not that you are just joining the course for joining sake. Right? Okay. Now, uses and competencies in nursing informatics. Uses and competencies in nursing informatics. I've already shared these slides via the student platform. That is a big class. So make sure that you go there, access them, and then get them downloaded. The nursing informatics competencies mean that nurses have adequate computer literacy and information management skills. For example, knowing how to use email, manage window applications, search databases, and ability to use games or LIMS for charting and medication administration are all part of the competencies. However, not all nurses possess adequate skills. The challenge we have is that we have not inculcated in you the need to own some of these laptops or computers. We are more serious about getting immediate results. So in terms of orientation, we don't encourage you to own some of these laptop or computers. So by the time you exit your program, it becomes so difficult or so challenging for you to bring to bear the thing that you have been taught or you have not fully been immersed. So right from your enrollment, the institution owns a duty to ensure that at least you make these computers or laptops available to you. The schools have made provisions, but the ICT lab are not enough to accommodate. The computers you have are not enough to accommodate all students, and that is one of the major constraints that prevents students from immersing themselves in these data interventions, right? So that has become a setback. But as part of this course, the smartphones that we're using are okay, but they are not enough because it is not everything you can do on your smartphones. So as you are making up plans, let's try to also consider getting laptop for the purpose of our own research, and then just to make us more informed. It is extremely important to identify the necessary informatics skills toward the technologies that facilitate information processing, communication, and then its exchange. Right. So we are going to look at nursing informatics competencies. We will draw some lessons from the models of scores acquisition by Stuart Frost and Patricia Benner. Then we look at how we can also let these competencies also, be shaped by those levels of what? Scores acquisition. So we are going to look at a beginner, entry or user level, intermediate or modifier level, advanced or innovator level. We are going to look at the core information or the core traits that these competencies or they should be noticeable or seen in either a beginner, intermediate, or advanced. If you look at the core information that defines a beginner or that can describe somebody as a beginner, if you assess them and then you notice you fall short, even though at the beginner level, then you encourage yourself that based on your shortfalls or weaknesses, you have to make some steps. Make sure that at least you become a bit informed or fill those gaps. And that is what we are going to look at. Aside this, we are going to also look at the use of information and communication technology. So that is technical competency. We will look at a beginner, whether a beginner possesses what technical competencies, whether a beginner possesses what utility competencies. If you are able to bring to bear some of the things that you have learned in professional context, like you are using LIMS or games to manage your patient, that is in a professional context, and that confirms what utility competencies. So we will look whether a beginner has utility competencies, whether a beginner is able to use automated information system in a professional context. Then we also look at leadership competencies, whether a beginner has what it is to plan for and use both the technology and information system. Once we are done with a beginner, we are going to look at what intermediate or modifier. And then we also apply the same levels of what competencies, whether technical, utility, and then leadership. Afterwards, we also look at what advanced or innovator level, whether those technical, utility, and leadership traits are also seen in those who claim to afford advanced. So if you look at all these things and then you notice that you fall short somewhere, then you see how best you cannot improve going forward. And that is the conversation on the table. Please, are you following me?
Yes, sir.
Okay, good.
Yes, sir.
So if you look at this Venn diagram, they are shaped by technical, utility, and then leadership. And then you see the intersection of what modifier, intersection of what a beginner, modifier, who is described as what intermediate, and that of what advanced or innovator. So the first one is what a beginner who possesses what technical competencies. Technical competencies, as described by Kaminsky, include the ability of a nurse to use word processing applications, demonstrate keyboard skills, use spreadsheet applications, use telecommunication devices to communicate with other systems, use email system to communicate with other care professionals. So do you know how to compose a message in a mail and make it available to the recipient? Do you know how to attach a file? All these are very important. And they say that at the level of a beginner, you should be able to do all these things, whether you are able to use word processing. One thing that will become very quite clear that when you are doing case study, hardly do students get time to prepare their own case study through typing. They are given to those people who have mounted, some containers around to do the basic typing for all of us. And once you don't, get yourself involved in some of these things, you graduate and get to the next level, and it becomes what albatross on your neck. And that is why quite a number of us are struggling in what research, because you still have to get somebody to do it for us. That is a major challenge for us. So you ask yourself whether you are how your ability to type, the speed of what typing a page of what let's say, content. Are you able to do that? So if you are somebody who type 1, and then maybe it takes you maybe the next 20 minutes, 20 seconds, before you are able to identify another key on your computer or let's say your laptop, then that one should also tell you that you are a beginner. And if you cannot do this at this level, where do you place yourself? Use spreadsheet applications and telecommunication devices. And this one is for a beginner who has technical competencies. I hope it is sinking well.
Yes, small.
Okay, so we are going to move on to utility competencies under same beginner. So you should be able to use the technology or information system in professional context. In order not to get you bored, that is the reason why I've reduced these core tweets into just 2. You should be able to recognize the relevance of nursing data for improving practice. So all the major relevant nursing information systems that are interfaced with our computerization, do you see the relevance of what those nursing data, and are you able to execute that into tangible benefits? That is also very important, and that is why we're just trying to contextualize what the pillars of nursing communication. Then it will let you know the relevance of what data, because without data you can't have what information, and then you can't have what knowledge. So all these are very important. And are you able to recognize the relevance of what the things you work with? Then recognize the limitations of what computer systems. So the computer applications that come with the whole computer systems, are you able to detect or identify those glitches or hitches that may occasion some decision making? If you are able to identify them, then you merit, somebody who is described as what having utility or competencies. But if you are unable to identify some of the basic, setback, and always have to go back to the IT people for them to intervene, then it means that professionally we are lacking something. And that is why you look at computer system, computer port, where when you have what disconnected cables, you should be able to identify and then fix them, and get to know the challenges that the system comes with, and what the system also does. You should be able to draw the line, and that is in professional context, and that will endear you to possess what utility competencies. Then leadership competencies. You should also be able to use computerized management systems to record administrative data, look at billing data, quality assurance data, among others. If you are able to use this one for the purpose of what administrative data in terms of billing, quality assurance data, you are able to have appreciation of that. Then that also make reference to a beginner who possesses what leadership competencies. Then we also have what use applications for structured data entry. So you are looking at classification systems. These are very important. So you group medical conditions or diagnosis into, let's say, entities, domains in terms of what ontology. You should be able to do those classes or structural arrangements. If you are unable to do this as a beginner at this level, then you don't see the leadership trait in you. And I know that we may have our own weaknesses when it comes to beginner level. So if you are seeing some of these weaknesses, even though somebody may say it is normal, but based on the discourses, it has confirmed that they are not normal, because you can't be a beginner forever. Right. I hope I can move on to the next one. That is intermediate or modifier. Can I move to that one? Then let's look at intermediate or modifier level competencies. Now, based on this conversation, they are saying that minimally, if you don't have anything at all, you don't know anything at all, you should be at the level of what? Intermediate or modifier. So in examination, you will see that which of the following is the most minimally competencies every partition net should, possess or should get. Then you see a beginner, you see intermediate, you see advanced or innovator. So at this level, every partition net should be seen at this level, that is intermediate or modifier. So if you are seeing some lapses as a beginner, I don't know whether you can graduate to intermediate. But at this level, I would say that because everybody is using electronic health records for the current setup, then we can all be pleased, at the level of what? Intermediate or modifier. But we have to go back to the beginner level and do some assessment to see whether we have all the qualities. If not, we need to sharpen our skills at the beginning level before we come to the intermediate. Then, so this one affects diverse areas of nursing where nurses work, and those who have mastered basic skills and use technology in inventive ways in their practice. So I think the system that we are working with, we have mastered, some basic skills that enable us to use such system to manage our patient. And that's a skill. That's a skill set. Gives a description of what somebody who is considered as what intermediate or modifier. Now let's look at the technical point of view for an intermediate or modifier. You should be able to apply technology support to provide evidence-based practice, right? So you are supposed to hone information from different sources that serve as enough grounds, or let's say evidential enough to support any intervention or decision making. You should also be able to synthesize data from more than one sources. So if you are having fully integrated system, then the system is open to the extent that you can have access to rich sources of information to support decision making. So on the basis of this, we can say that you possess technical competencies. You demonstrate awareness of an ability to access data and information from multiple sources. And that is what technical competencies. Now, in professional context, let's look at utility competencies as it does affect an intermediate or modifier. You should understand basic and complex concepts and processes of various computer systems and how they relate to practice. So it is not out of place that we review computer systems and then their applications. You should be able to know the basic features, right? That comes with key decision making. Then the complexities, or let's say issues of incompatibilities, you should be able to know all of them and see how they relate to your work or it does affect your work. Synthesize data from more than one source, it has already been exemplified. Then I'm more concerned about upholding ethical standards related to data security, confidentiality, and client right to privacy. Security governance or framework is very important. Now that we have gone paperless and everything is digitized now, you need to also be more careful about not compromising patient sensitive information. We should ensure that we safeguard patient relevant information through adequate security framework so that people who are intruders, who do not have authorization, cannot hack into our records and do things that may suit their own parochial interests. Once there's occurrence of data breaches, you know the potential consequences. Here we gloss over quite a number of things, but in our advanced countries, data protection law is very, very, very important, and there shouldn't be any breaches. That is why when you sign any document, these, data security measures are strictly enforced, so that if you don't take your time to appreciate it and then you sign, whatever you do will be used against you. So please, you have malware, Trojan horses, viruses that people who have malicious intentions should deliberately manufacture just to corrupt our files or gain access to our patient information. That is why we need to call for adequate security measures to ward off against cybersecurity threats, among others. Then the last one, for intermediate or modifier who has leadership or competencies, you should be aware of your rule. Aware of rule of nursing informatics in the context of health informatics and information systems. So this one, what it means is that we have already reviewed the rules of what nurses in informatics. So you should be aware of what diverse rules of what nurses in informatics and see how you can also be guided to sharpen your skills. I know quite a number of, some students have expressed interest, and the foundational knowledge that we bring to bear is the nursing knowledge. But sometimes it's also very important that you also try to learn other disciplines to make you complete or all round. Nobody can take it away from you, your professional knowledge that you bring to bear, but you also need to be all round. I've seen nurses who have, gone outside their field and they specialize in other areas. So whatever they find themselves, they are able to thrive. Okay, so some students have also enrolled into master's programs in informatics. So all these are very important to sharpen your skills. And then participate in policy and procedural development related to nursing informatics. Policy development is very important. So at the intermediate level, in terms of decision making to procure your software, run other applications, you should be well informed. And all these are traits that should be seen in a leader at the level of intermediate or modifier. Then the last one will be advanced or innovator level competencies. This one can be matched up to expert level. Once you have advanced, it means that you should be seen to have special traits that may not be seen at the level of a beginner or intermediate. This one includes diverse areas of nursing where nurses work, and that person is considered to have mastered expert skills and use technology in design. So in the designing and configuration of nursing information systems, once you have advanced or you are seen as innovator, then you can't run away from this rule. You plan and coordinate the use of technologies and informatics theory in nursing. For instance, I work under someone small, and then the person happened to be a pharmacist, right? As it stands now, she is the one who trained all the medical professionals, right? So she's in charge of anything informatics related or technology based or applications. She is in charge of that. She has gone a bit off, the profession, even though she stays in the profession, but other portfolios. That is also immensely benefiting the facility, right? I was just asking her some time ago, what was her motivation to venture into this? So not knowing that she has done master's in informatics, and at this level, she is now the one in charge of training all the medical professionals, right? So care coordination, designing, planning, and everything you should be seen in somebody who has advanced. And let's look at technical metrics that determines somebody who has advanced. Now you need to participate in the design and development of information systems. And that is why, as far back in 1980, nurses were involved in the design of their own information system, and they went a step further to purchase their own software, right? You also develop inventive ways to access data and interact with information systems. Somebody championed the use of OPD number as the blueprint for getting access to the computer system, and hence easy accessibility to patient records. And these are inventive or innovative ways to get access to that. Participate in design and development, and develop design and development of new applications for nursing practice. Then participate in developing new methods for data and information organization. Utility competencies. Professionally, as somebody who has advanced, you should be able to do needs assessment. How many computers are required at a particular ward? How many computer systems do we need to beef up? System selection, very, very important. The software that you select, other applications, all of them are part of what? Somebody who has advanced. And this one will also confirm the diverse rules of what? Nurses in informatics. Then implementation and maintenance throughout the phases of system implementation, whether the pre-implementation phase or the post-implementation phase, it should be at the heart of what? Such activities or implementation. Recognizes factors and issues related to human-computer interface or interactions, right? You need to do that. So when you're talking about human-computer interface interactions, if you are very deeply involved in all the design processes, when you come up with any software or computer, you make sure that they are in good shape, they are being configured or designed very well, and therefore users may be at ease in using or interacting with the interfaces. But if you go and then the interfaces or applications are not usable, users may shun and what? Usability principles. And those usability principles may be inclusive of what? Learnability. Whether when users learn, they find it so easy to get adjusted or adapted to it. Then memorability. When users have also learned how to use the system after a sustained period of not using it, let's say they are on leave and they come back, are they able to remember and then use the things we were doing? And then again, you should also have the system should be designed to have ability to identify error or maybe recover from what errors. Once you see error, can you use the same system to remedy the error? Very, very important. And then you look at how effective, efficient, and satisfaction people or users derive from what? The system. All these are quality traits of what? Usable systems. Right? Okay. Then increasing of what? Nursing data and information, the design of plan information systems. Doing migration of what? Our raw data into computerized system. The IT people cannot do it alone. They are seen as what? Experts when it comes to those innovations. But in terms of our input onto the computer system, we are very key. And we need to guide the IT people for them to do the transition. And all these are part of what? The traits that are seen in somebody who has advanced at the level of what? Utility competencies. Then the last part of the advanced or innovator level is the leadership competencies. You develop and participate in quality assurance programs, always looking for excellence, trying to make sure that the system gets more improved. Participate in patient instructional program development. For how long are we always going to engage our patient through health education? Every 7 a.m. or let's say 7:30, we organize our patient at the OPD. We educate them before they move in to access their services. But have you also considered instructional manual just to guide them? It is also very important. So if you are going to completely go electronic or maybe digital way, the patients are not aware because they don't have representatives who may represent their interests, unlike the PTA system, where we have parent-teacher association, where they may represent the interests of what their works. But when it comes to the hospital, we don't have inclusion of what patient leaders who may also, get in touch with what management for us to also shape things to reflect, the things they also want. When you are going to procure the software, you leave them out. You don't guide them. When they come and then there's entire complete change within the system of pay or care delivery, then they become confused. So a leader who has advanced should be able to come up with all these roadmap to guide the patient. Then the last one is what? Ergonomic design of what? Workstations, bedside access stations, and portable apparatus equipment. we are looking at ergonomic use of computers. You go to the world. I think we pay more attention to the setup because you see the computer mounted on the table. Then you also see a chair where your back may be laying to the chair. Okay, that's a very good one. Then you see the computer up to your shoulder level. Okay, in terms of where they have been placed or mounted. But when you come to our various rooms, you don't pay attention to ergonomic use of what computers. So very soon we have some pain or back pain because we are not positioning ourselves for the posture is so wrong. And that is the reason why sometimes we have what back pains among others. All these are some of the traits that an advanced or individual level should be able to exhibit to guide what users in order to ensure the right posture to use computers, their chairs, and everything. This will bring us to the end of what uses and competencies in nursing informatics. I'll rest here and get your views, whether you have something to add up, there has been some omissions, or you want to maybe ask some questions. Then you move on from there. Hello.
Hi.
Hi.
You are following proceedings, I mean, quietly, right? Okay.
Yes, please.
Yes.
So the platform is for you now. Ask your questions or maybe contributions. So if you are asked to describe nursing informatics competencies, list examples. List with example the different types of nursing informatics competencies. I hope you'll be able to describe the way I mean explain myself, right? Obviously, share. Me now can I say anyway. Hello.
Hi.
Gus, you cannot say I'm not into this topic. Without, if all of you agree that I can move on, then I'll do that. But let me hear from you. So due to rapid innovation in healthcare, there is the need to measure and enhance nurses' informatics work, skills, and their knowledge, right? Can I make progress from here? That is when you don't have anything to say. Can I move on?
Yes, sir.
Yes, sir. Yes, sir.
Hey, so if I ask you to list with examples, various competencies of nursing informatics, will you be able to do that?
We will manage.
I do management. Yeah, very fine. Why? Okay, so let's appreciate informatics tools. This one, don't let us get confused because we have already reviewed informatics tools, where we got to know major tool is a computer, then standard, I mean, any communication system, that is ICT. Then we also look at what other tool did you look at? What other tool did you look at apart from computer systems? Then we also look at anything ICT, that is information and communication systems. We look at network, internet. Then we also look at what? I mean, what again did you look at? Formal medical terminologies, right? All these are very important. Then what again, aside formal medical terminologies, what again did you look at as enablers or tools in informatics? There's one that is missing. And what is that? When I say standard treatment guidelines, all of them are part, but we describe them in a different, context. So what is that? Hello, what is that? What is left out? Hey, you can't tell me that one.
Sir, please, your line is breaking.
My line keeps on breaking, right?
Yes. So please come again.
Is it okay now? I'm asking you that you're looking at what informatics tools, and I don't want you to be confused with what you're going to look at, because we got to know about computers, information and communication systems, formal medical terminologies. And there is also a major one that is missing. And I'm asking you, what is that? Did we get it?
System units.
System unit is part of our computer, right? So what again? If you cannot mention them, then I'll have to skip.
Sir.
The mouse.
Hello.
The mouse.
All of them are part of our computer and then its applications.
Internet.
So you can all of them are part of computer systems.
Sir, hardware and software.
So what did you review as well? What? They are all part of our computer systems. Okay. So what are the tools that are used in informatics? If you're unable to tell me, meaning that you have been skipping lectures, right?
Informatics tools.
I wanted to. So you are not being direct or specific. So which of them are the two? Please, can you put the person at the meeting room for us? The one who is not ready to. Okay. So you have forgotten about. We spoke about formal medical terminologies, right? And then clinical guidelines, right? That is what I wanted you to. That is why I initially said that standard treatment guideline, but I want you to put it in proper, perspective. So clinical guidelines. Okay, I don't want you to confuse them with what you are going to look. Going forward. According to ACOF, nursing informatics can be examined in terms of theory surrounding data, information, and knowledge. Nursing practice begins with the use of data. In our society, more often than not, we are either using technology to capture the data that comes in and out of the facility. So by the end of this session, students should be able to explain the available informatics tools and how to apply those tools. Good nursing practice requires detailed record keeping that is comprehensive, timely, and then accurate. Without complete recording, there is no evidence to prove that care was provided to the patient. And in nursing practice, there is a saying that what is not recorded has not been done. So if somebody comes to the hospital, you have all your available data, then everything is recorded. Those interventions are kept in patient folder. And the folder is misplaced, or we can't see the folder. What are you going to use as evidence that you have really managed the patient? Because you can't have the people's history or records. And there's nothing that could be more suggestive of what you giving attention to the patient, even though you can be sure of what the services you are provided, but it is not confirmed in writing or documentation. And that is why there's a saying that what is not recorded has not been done. Now, let's look at this. Nursing and health data may be classified into 4 basic types. This is examinable. In examination, you may see something like this. I may introduce an outlier. Then you will pick up the odd one. So let's take note of that. Nursing and health data may be classified into 4 basic types. First one is resource data. The next one is patient demographics or patient or client demographics. The third one is activity data. The next one is health service provider data. These primary data are recorded manually or collected electronically, with manual collection becoming obsolete in terms of use, and that one is more prone to making errors, right? So I want you to bring your voice to the conversation. What, in your view, are activity data and health service provider data? What is the difference between the two? Activity data and health service provider data. Let me get your views on this. We got the first one, resource data. Very clear. Patient or demographic, client demographics, very clear. What about activity data and health service data? Let me get your views on this. It seems I'm talking too much, so come in. Hello. Okay, now let me go to Judith. Judith, can I get your view?
Yeah. The activity data, I see it to be what patients do in the ward, like the activities they perform and what the activities nurses to perform for them in the ward. I don't know if
So that's good. What about the health service provider data? Hello.
Hi, sir.
What about the health service provider data? I think we are quite clear with the activity data or clinical data. What about the health service provider data? Okay. Now let me go to Prof. Elijah.
Hello, sir. Please, can you hear me?
Yeah, I can hear you.
Yeah. My sister said, all right, activity data. I think what my sister said, let me add something small. Basically, those tasks that we normally perform, the procedures that we perform within the health facility, those are basically the activity data, the record that we keep on them. And I think example could be maybe the number of patients that have been seen at the OPD or at the midwifery side, the number of deliveries that were conducted. So those are basically some of the examples that I will give under the activity. And when we go to the health service data, for example, over here we can say basically the data that we have gathered from our activity, how we have aggregated them, how we have analyzed them, and the interpretation we give to such data. So for that matter, let's say our maternal mortality rate, for example, and if possible, maybe the hypertension prevalence at the hypertensive clinic. So basically, those are some of the few things I want to cite here. Thank you.
Okay. You have heard from Prof. So that's a very good submission. Can we also have maybe different perspective, or maybe what you want to say confirms what our brother and sister have given us? So we should take that and then move on. Okay. So I think all the things you have said are in line with what is expected. So let's begin this way with the resource data. Even though you have seen example like financial information, but you can also look at it from this point of view. Medical supplies, looking at availability, usage, and stock levels. All of them are part of what resource data. The equipment that you have, that are functioning, and how you maintain them, all of them are part of your facilities or the infrastructure, human resources. All of them are seen as what? Resource data. Then when it comes to activity data, right from, let's say, vitals, and then through from admission through to discharge, all the things that are the major activities that are seen in nurses in terms of their work. That is the activity data or the clinical data. Then in terms of health service provider data, in fact, that one goes beyond the activity data. For instance, if you want to look at this one, is more administrative. So he made a profound statement that if you want to, let's say, look at maternal mortality rate within the facility, or let's say the number of people with hypertension or prostate cancer, all of them can be classified as health service provider data. But in this context, we can also see that with regards to all the things that administratively are done, whether employee development, including capacity building, all other relevant things that are seen other than the clinical activities, that is considered as health service provider data. Am I making myself very clear to you?
Yes, sir.
Okay, so you can also consider even staff performance appraiser. All of them are considered as health service provider data. So that is it. Now let's make progress from here. I said that don't be confused with the tools that we have already reviewed. If you are looking at quantitative data collection tools or instruments, inclusive of questionnaire, interview, surveys, quizzes, assessment, all these are data collection tools. They are not the tools themselves. They are just meant for data collection or for the purpose of research. And that is why I said I don't conflict this one with the major tools that we know. So if I ask to outline the tools in informatics, as you are mentioning, let's say clinical guidelines, you are making mention of computer systems, among others. Don't conflict that with this one, because these are just for data collection. Okay, so let's be guided by this nice quote. The best way to find yourself is to lose yourself in the service of others. Mahatma Gandhi. So I keep on telling students that the moment you are enrolled into nursing program as a student, that is why your journey of sacrifice begins from. You are going to sacrifice your precious time and everything just to the service of humanity. So that is why you need to get that kind of empathy and everything, right? So that is, you should be guided by this one. Are you sacrificing towards the cause of humanity? If you are doing that, then that is fine. If you are not pulling, then you need to get motivation to continue to sacrifice. Anyway, nursing aspect of health informatics systems. The electronic health records or using electronic medical records, devices that collect health information electronically, and other electronic information standards. Health informatics nurses are responsible for managing the information that come in and out of the facility, because you are generators and consumers of large data set of information. Okay, or in an attempt to improve quality of care. Okay, so let's look at this. By the end of this session, students should be able to discuss nursing information systems, explain sources of data capture, and list the types of point of care devices. We are going to look at how best to manage our various work through computerization. At the moment, how our works are organized with our computer systems. Is that how it's supposed to be done? We are just using one computer or two at various world, male sword or female sword. Is that enough? So by the end of the journey, you will know the modern way of managing our various world through computerization. Now, these are some other people. Education is our passport to the future, but tomorrow belongs to the people who prepare for it today. Malcolm S. You don't have to be great to start, but you have to start to be great. Stigler. Now, nursing information system is part of healthcare information system that deals with nursing aspects, especially the maintenance of nursing record. If one considers the original principle that Campbell identified, when looking at activities nurses perform when caring for patients, nursing rules falls into 3 global categories. The first one is what? Managerial rules activities. The first one is what? Managerial rules or coordinating activities. For example, order entry, resource reporting, requisition generation, and telephone booking of appointment. The current information system, the GIMS or LIMS, help nurses with these what? Activities. The second one is what? Physician delegated task. Then the next one is what? Nursing autonomous what? Functions. We are going to look at what goes into each role as being described. Now let me take it again. Managerial rules or coordinating activities. For example, order entry, resource reporting, requisition generation. So we are all witnesses to the use of electronic health records, where we have, the procurement unit, or let's say, that's the supply chain unit. All of them are tied to the electronic health records to ensure we are able to make requisition. Pharmacy system is also tied to, the electronic health records, where nurses can also request special, drugs, those urgent or emergency drugs, right? All of them are part of what? Managerial or coordinating what? Activities. And then if you also want to put somebody for appointment, it is also part of what? Managerial or coordinating activities. Now, the second one is physician delegated tasks. The current system captures these from the physician's order entry set and then incorporate them into the patient care plan. The third one is what? Autonomous nursing function. So now my question to you is that physician delegated tasks, autonomous nursing functions, do we see ourselves in terms of our responsibilities or duties in physician delegated task, or our task call for autonomous independent functions? Where do we draw the line? Are we called for delegation, or we are there to ensure independent of what? Our functions? Did you get the question?
Sir, come a bit clearer.
Okay. Now, what I'm trying to say is that we are talking about physician delegated tasks. And I'm asking you whether you see yourself or you see your roles in delegation, your responsibilities in delegation, or you still see yourself as autonomous, being independent of your functions. Where do you draw the line? I hope it's quite clear now.
Clear.
Yes, sir, it's clear.
Okay.
Now.
Okay, so where do you find yourself? Are you called for the purpose of delegation, or you are independent of your responsibilities? Or there's overlapping responsibilities or collaborative work? Let me get your views on this.
Some of the activities that nurses perform in the facilities are physician delegated tasks, while others are autonomous nursing functions, just as the point has stated.
Can you come clear on this one? Can you open up what is considered as delegation, and what also make your responsibilities independent of your work? I just want you to open up what goes into delegation, and what are your rules in delegation, and what are your rules in autonomy?
Okay, so when then the doctor writes an order that maybe you should administer such a medication to a client, what you are doing is you are following orders in this case, and then the nursing diagnosis that you as a nurse will do, and then provide care for your clients. That one is not something that the doctor will order you to do, but you as a nurse will have to make your own observation and assessment and come up with a diagnosis and then manage the patient based on whatever findings that you find. So that one is not under any direct orders of the doctor, but an autonomous nursing activity.
Okay. I think that's very clear. So if you look at delegation, that is why I said that there are some overlapping rules. But nurses are trained independent of what their functions. Just that those responsibilities overlap with what? Delegation. So it is not under delegation, but a cause for collaborativeness or teamwork. So that is how you should look at it. Then autonomous nursing function. Characteristics of nursing professional nursing activities. When knowledge unites to nursing is applied to patient care. So you bring to bear the knowledge that you have acquired, the level of acquisition of what your skills or skill set that is brought to bear with decision making. That is considered as what autonomous what nursing functions. Your independence of your function, just that some of your rules overlap with what delegation. So that is just about it. So in examination, I can say that nurses rule in terms of decision making falls into 3 global rules. Which of the following does not exemplify this position or context? Then you will say we have what managerial or coordinating activities. You say physician delegated tasks, autonomous nursing function. Then you get an outlier. So it is up to you. So let's take note of this. Going forward. All the 3 categories, again, managerial, physician, delegated tasks, autonomous nursing function, must fit together to create a fully operational system. The present system, while they release nurses to focus on professional nursing activities, the future will call for inclusion of decision support system for the purpose of what? Improving nursing care plans. So let's take note of that. Now, what do you see here? I made a very important point about how best we can modernize our various world. While things are changing, we need to also look at emerging or new ways of what improving our various world through computerization. When you go to some facilities, per what I have seen, you go there and then computers are on the table, just one, managing, let's say, about 10 or 20 beds. The standard way should be that every patient bed should have a mini computer. Every patient bed should have a mini computer that is brought closer to the patient bed. But what you are seeing here, you see the computer has been laying on top of the patient bed. It could be that because of space, or there are equally important equipment over there. So if it is not, the space is not enough, you can mount this on top of the patient bed. But the most important thing is that it should come with keyboard functions so that it can support documentation. As you see them, doing some typing, right? That is one aspect of it. Now, with these kind of demands, manual data processing has become in supporting management decision making. Please, the one who is disturbing us, can you move the person to the waiting room for us? The advantages of automation extend far beyond the ability of a computer to crunch numbers. So, in terms of automation, it is not just about data entry. It goes beyond this, right? How can nurses use computers in their daily work or routines? The most important here is that we are advancing the use of electronic health records to improve upon documentation, and then again to also improve upon our immediate access to patient records, right? And for better options in terms of treatment. That is one of the intended purpose of electronic health records or computers in care delivery, right? To provide information assistance to nurses, source data capture, nursing data standards, and decision support system must be addressed. So we are looking at source data capture, where information emanates from and where information stays. Then are we also enforcing nursing standards in terms of what those resources or sources of information. Then does our current system also come with what decision support features that also assist care providers in making clinical decisions? So we are going to look at nursing data, source data capture, we look at nursing data standards, and we also look at decision support system extensively, right? These three areas are crucial to providing computer support for nurses in the delivery of patient care. Source data capture here means gathering data and information about a patient, where it originates, that is with the patient. So the concept of terminal by the bedside was introduced in the middle of 80s, right? So I remember some time ago, somebody was just saying that in our facilities around, you will see in our various ward where patients are having those on admission. You have a small computer, please. Your bedside. Is it applicable in a local context here? It is highly possible. So we just have to learn to see how we can also improve the things we do. Most experts agree that bringing the computer access closer to the patient, locating it at the point of care, is a valid premise, and clinicians appear to favor the bedside computing. You see, the challenge has been that we are using the paper system, that is the food desk, alongside our computers. So doing what run, you need to make data entry onto the folder, then we transition that onto the computer system. When it happens this way, nurses will see this as what workload, because that is what double work. And clinicians are against this, and they also don't see themselves to be the one to be doing the entry, and that has been the major challenge. But if it becomes the normal way of what managing our ward, where every patient bed has what one computer, small computer unit. Whenever you do any entry or you give attention to the patient using the system, it is what transmitted to the workstations. That is the database repository or infrastructure. So it doesn't call for another entry or documentation. Okay, and that is the reason why clinicians appear to favor bedside or computing. So if you look at this one, we see this wheel where it comes with a computer system that we can pull back and forth, right? So it is also another way that we can also look at it and then improve upon our work. Instead of getting, let's say, one computer for about 20 patients, we can also go this way. And this one is very good. Okay. As more facilities and organizations implement source data capture system, including bedside terminal, the concept will gain prominence, or it will be accepted in the industry, and it will become a routine standard practice for all nurses, right? Criteria for source data capture. Because of our time, we have about 3 minutes, and I don't want us to be taken off abruptly. So I'll pause here, then we will reserve this one for next week. So if you have any other questions or anything to say, let me hear you. Then I also want to find out, when are we going to do our mid-semester? Have you checked the calendar? Can you confirm that, so that we look at this very well and then we get consensus on when it is ideal for us to have our mid-sem? Then we do that. So over to you. Hello.
Hi, sir.
Time is almost up, so let me hear from you, and then we call it done. Come back next week. You don't have anything to say? Oh, feel free. Feel free, and then just express yourself. What you make of what we have done today, and then the impending mid-semester. When are we going to do it? Have you planned towards that? Then we settle on the time next week. So I want to find out from you. Okay. So you have uploaded your slides or lecture notes on the V class. So just go there, access them, and download them. I think they are up to date, with the exception of what? I mean, this one. I've already shared the competencies, so I'll also add this one within the course of the week. So if you have any further concern, reach out to your reps, and I'll get to know. In the absence of any question or contribution, then I suggest that we call it done for today. So on my own behalf, thank you so much for making it happen today. I wish you very well, especially enjoy a very successful weekend, and make sure that you stay very safe as prepare for next week. All the best. Bye bye.
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 Thank you, sir.
Thank you, sir. Bye. Bye. Say bye.
You just free for class.
Yes, sir.
This informatics through there is not easy. Hey.
Please, did he give any information because computer went off? Hello? Who is here?
Hello. Hello.
Please, did he give any announcement? My computer went off. I just came back.
No, he didn't give any announcement.
Oh, okay.
But he
He
just
only
said
said we should decide on when we want to take our midterm and then tell our reps to inform.
Oh, okay, okay.
and
Thank you
also
very
the
much.
notes are on the V class.
Okay, okay. Thank you.
You're welcome. Bye.
Bye.
Forgive. Hello. Hello.